Dana ma'am, please take it.
I'll share the screen, please. Are you able to see the screen?
No, ma. Yes.
Yes?
Yes, ma. Started screen is there.
Yeah. Can I start my slideshow?
Yes, ma. Can I start to welcome others, ma? Good afternoon to one and all. I feel very privileged on this International Women's Day to host a webinar, especially on women, prevention of illness and promoting wellness in women. That is our theme today. And we all know world is telling gender equality today for a sustainable tomorrow. That is a slogan. And today we had a large rally taken in the morning.
Madam, your audio is not there.
Oh, audio is not there. Sorry. Okay, good afternoon to everybody. At the outset, I welcome one and all for this webinar on preventing illness and promoting wellness in women on the day of International Women's Day. Actually, gender equality today for a sustainable tomorrow is the slogan for this year. And DIRA is one of the, DIRA or Stop Violence Against Women is our Foxy president has given this slogan to all the Foxians, all the gynecologists all over the India, so that we have a public awareness drive for violence, for stopping violence against women. On this day, I'm very happy to have a webinar on selected topics and especially for promoting wellness of women. Over to Dr. Dana.
Good afternoon, ma'am. This is a short agenda of what we are going to have today. And after invocation, lighting the lamp by Dr. Premlata, President, and rendering of Foxy prayer by Dr. Geeta Lakshmi. If she's not available, I'll do it. And I welcome our esteemed chairpersons, Dr. Meena ma'am and Rohini ma'am. Rohini ma'am will join shortly. Okay, and we'll have 4 speakers with a short break in between for audience interaction, and we'll end the program with a vote of thanks.
Dana, Dr. Kunjavi will be talking first. We have informed Dr.
Dr. Premlata has already given the welcome address. I'm happy to introduce her as a president of Oxy 2022, and she's a consultant head of academics at Mehta's Hospital, Chennai, and she's a former professor and director in charge of MMC and IOJ respectively. She has presented papers in national and international conferences, and she's a expertise in tubal microsurgery, and she's received the Lifetime Achievement Award from Dr. MGI University.
Okay, actually all events start with the prayer to the God. Now we'll go for the Tamil Thai Valthu and light up.
And to render the Oxy prayer, Dr. Geeta Lakshmi is available. Otherwise, I'll do the Oxy prayer. I'll render the Oxy prayer.
Yes, Dana, I'm available here.
Yeah, please. Dr. Geeta Lakshmi is a registered and senior consultant at ISO KGH, treasurer Oxy, and she has published several papers. Special interests are in high-risk pregnancy, adolescent health programs, and medical education. Can start, Geeta Lakshmi.
Yeah, thank you, Dana. I shall go with the Oxy prayer. Thank you, God. In humility we gather. In gratitude we pray for things you have given us all the good. Shower us with your blessings to pass on the healing touch and to celebrate the arrival of each new life and mom reborn. The courage to deal with it all when things are not perfect, to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love.
I'm happy to introduce, happy to call upon our president to introduce the chairperson for this session.
I'm happy to introduce chairperson, Dr. T.S. Meena. She's a professor and deputy director of IOG, Madras Medical College right now. She's a UG PG teacher for the past 23 years with a vast teaching experience. She's a master trainer in Tamil Nadu NCD training program. She's a faculty in various national and international conferences. Areas of interest are high-risk pregnancy obstetrics, social obstetrics, cancer screening. She's a former member, Board of Studies, Tamil Nadu, Dr. MGR Medical University. Dr. Meena, please take the dais. The other one?
Meena ma'am, kindly introduce Dr. Kundavi Shankar. She'll be the first speaker.
Thank you. At the outset, I would like to wish everyone Happy Women's Day, to the team Oxy as well as the august audience here. And it's my great privilege. The first talk will be on distressing midlife problems and solutions by Dr. Kundavi. I think she needs no introduction because she's very well known in Oxy. She's the HOD, senior consultant in Madras Medical Mission. She's the lead consultant for fertility and a honorary joint secretary of Oxy 2022. She's a renowned national board certified obstetrician and gynecologist and a specialist in reproductive medicine and laparoscopic surgery. And over to you, ma'am.
Can I introduce Dr. Rohini? Rohini has joined. Can you put the Rohini? Dr. Rohini is a professor in Savita Medical College, and she's a professor and unit chief at Savita Medical College. Special interests are high-risk obstetrics, vaginal surgeries, and laparoscopy. We call you upon to chair the session for this session.
Dr. Kundavi, you can share your screen.
Yes, ma'am. Yes, ma'am.
Thank
Rohini,
you.
you can be a...
Thank you, ma'am.
Can the slides be off? Yeah. Can you see my slides?
Yeah.
Yeah, yes.
Need for slideshow, pa?
Thank you, Oxy, for this opportunity, and thank you so much for adjusting my talk, friend. And distressing midlife problems and solutions. We know that midlife crisis ahead during menopause. Menopause is a transition phase from the reproductive to the non-reproductive phase in a woman's life. It's nature's protective phenomena against reproductive morbidity and mortality in the aging population. It sets the stage of aging and accelerates the process of non-communicable disorders. The diagnosis around FSH is more than 40 international units, at least 4 weeks apart. And AMH becomes undetectable, and menstrual irregularity is the only objective marker to define and establish a menopausal transition. And according to the latest WHO, we know that the life expectancy in India is about 70 years and expected to increase to 77 by 2050. And non-communicable diseases accounts for about 60%. The estimated mean age for the menopause is 46 years in India. The hard facts is like, it is reported that osteoporotic fractures occurs 10 to 20 years earlier in Indians when compared to Caucasians. And the myocardial infarction attacks about 4.4 in Asian women at a younger age. And the type 2 diabetes occurs a decade earlier than the Caucasians. And the prevalence of hypertension in India is about 29%. And it's projected to increase by around 115, the cardiovascular disease from 1990 to 2020, and the cerebrovascular disease by 104%. So the above facts indicate that the need to have a well-planned and cost-effective systems in place to promote a healthier and active aging population. And it is most important to distinguish between a symptomatic and an asymptomatic menopausal women before we start the treatment. And all of us know the famous 7 witches of the menopause, like itchy bitchy, sweaty, sleepy, bloated, forgetful, and psycho. And let's see what each one does to us. And these are the various symptoms and signs of the midlife problems like hot flushes, irregular periods, night sweats. You have a vaginal dryness, urinary urgency and infections, loss of libido, depression, lack of energy, and various symptoms as well. People have divided as physical menopausal symptoms and psychological menopausal symptoms like hot flushes, irregular weight gain, and headaches, whereas psychologically you have the mood swings, loss of libido, depression, and anxiety, and etc. Again, another people have divided as a estrogen deficiency and progesterone and a testosterone deficiency, and the symptoms are depending on the deficiency of these hormones. The quick question is that if you have irregular periods, are you having any hot flushes, any vaginal dryness, painful sex, any bladder issues? How is your sleep? How is your mood? Then we know that we enter into the midlife problems. And coming to the irregular periods, we know that it is because of the hormonal imbalance, changes in the uterine lining, ovulation abnormalities, and people do have a shorter periods, either a longer periods or extremely light or a heavy periods. And people say that by you adjust your diet, alternative therapies, and pharmacological like oral contraceptives and HRT has been advised. And when you have a patient with postmenopausal bleeding is about 10 to 15%, and if you have an endometrial thickness of 3 to 4 millimeters in the vaginal square, do not require any sampling. Whereas an asymptomatic and early postmenopausal, if you have more than 11 millimeters, should need a biopsy as well. And if an endometrial biopsy tissue is reported as insufficient for diagnosis and is only about less than 4 millimeters, follow-up is sufficient. Whereas you have a homogeneous with hormonal therapy and a hypertensive medication, the acceptable combined thickness is about 6 millimeters. And coming to the vasomotor symptoms, they present as hot flushes, cold sweats, and night sweats, and could be reported in the menopause transition. And it generally lasts for about 6 months to 2 years. We need to exclude other causes of flushing before you start the treatment. And these hot flushes, they have a reddened face, perspiration, cold chills, sleep disturbances, and a rapid and irregular heartbeat. And we know that stage 1, it's because of the estrogen withdrawal, then because of the decreasing circulating endorphin and catechol-estrogens, and there's an increased serotonin norepinephrine release from the hypothalamus, resulting in the hot flushes as well. And what do we do with them? Lifestyle modification. The most effective treatment is hormonal therapy. Low-dose oxypills, if not contraindicated, may be used at menopausal transition. Non-hormonal prescriptions may relieve vasomotor symptoms, but they have their own side effects. Complementary and alternative treatment should be advised with caution. And coming to the mood swings, because they produce hormonal changes, cause sleeplessness, stress, sexual dysfunction, and changes in the body and negative attitude. The symptoms like sudden bouts of sadness and inability to concentrate, lack of motivation, and increased fatigue. Again, the diet, exercise, and you have a good sleep. The management, like you do a breathing exercise, keep a journal, I think walk and avoid the triggers, and probably an antidepressants and the non-pharmacological remedies with the diet could be adjusted. Coming to the difficulty in concentration, they have a very unclear and fuzzy thought process, losing a train of thought, forgetfulness, and probably needs to taken care as well. Coming to the prevalence of dementia is about 0.6 to 3.5% in rural India and 4.8% in an urban India. And the risk factors like family history, genetic factor, cardiovascular risk factors, physical inactivity, diabetes should be ruled out. And the estrogen therapy is not recommended for reducing the risk of dementia as well. For the best preservation of the memory and cognition, the importance of you need to have a good overall health, good cardiac and vascular health, exercise, maintain an active mind. At present, the hormonal therapy is not indicated for the neuroprotection. And coming to the memory loss, we know that the neurotransmitters get affected, decrease cognitive functions and memory lapses. Evidence support that the relation of estrogen to cognitive function. Women face problems with memory loss and difficulty in concentration at the transition. A definitive role of hormonal therapy for treating cognitive symptoms without vasomotor is again lacking. Again, patients have been advised to go for a lifestyle modification as a first line. Cognitive behavioral therapy, use of benzodiazepines or melatonin agonists can be used for a short term. And the mind-body therapy such as the yoga and Tai Chi have some evidence, but needs further rigorous studies to prove its effectiveness. And coming to the vaginal dryness, like itching, painful intercourse, frequent urination, and burning and irritation may be because of the low estrogen levels, thin vaginal tissues, and low vaginal lubrication, inflammation, and probably you need to have a lifestyle changes. and alternative medicines, plus you have estrogen replacing creams or the rings and HRT as well. And the symptoms of libido like vaginal, it may be because of the vaginal dryness, painful intercourse, lack of sexual desire, frustration and depression, maybe because of the vaginal dryness and loss of arousal and low libido. And probably is like diet, exercise, and probably you need to have a special affection towards your partner and not focusing on sex because that is painful, talking to each other, making time for intimacy. So probably use a lubricants, hormonal replacement therapy, and therapy for a counseling is a need to change the for the libido management as well. And the sexual problems, we know that sexual response to a partner is significantly related to a baseline feelings towards a partner. Vaginal atrophy with aging may lead to a dyspareunia, so probably it could be corrected by the local estrogen therapy. Tibolone is a good option since it contains androgenic activity and can be used to treat lipid problems. And coming to the urinary symptoms like during menopause, it prevents as a vaginal dryness in 32%, pruritus vulvae in about 10 to 17%, and dyspareunia and urinary urgency in about 10%. The vaginal lubricants can be recommended for the subjective symptom for the improvement of dyspareunia. Vaginal moisturizers can be offered for vaginal dryness. Local estrogen therapy is the first line of management. Again, lifestyle modification, bladder drill, and pelvic floor exercises are recommended for urinary incontinence. Coming to the depression, that is, they do have a persistent sadness, feeling of emptiness, low self-esteem, concentration problems, sleep abnormalities, and the significant appetite changes and everything. Again, you talk with your friends, do an exercise, eat healthy, and de-stress yourself. Depression is a significant increased risk for a new onset depression in women during the menopausal transition. In a within women 8-year study to determine the risk factors, what people found that was a diagnosis of depression was 2.5 times more likely to occur in the menopausal transition compared with when a woman was premenopausal. And the joint pains, I think most of us do phases like pain or a discomfort, swelling, stiffness, and the limited mobility because of the decreased collagen and the bone and the cartilage loss and inflammation producing this joint pain. And these joint aches and pain are the symptoms reported very common at midlife. While women are obese and depressed are more likely to experience joint pain, there also appears to be an association with the menopausal status with the peri and postmenopausal women experiencing more joint pain than the premenopausal one. Coming to the skeletal-muscular system, where the two stages of osteoarthritis, they said that stage 1 and 2, you have a lifestyle modification, drug therapy, and a physical therapy. Whereas if stage 4, 3 and 4 probably needs a surgical intervention. Coming to fatigue, that is, they become very apathic, irritable, sleep loss, muscle pain, and memory losses. And again, how do we overcome this? You do an exercise regularly, use your bed right, pick a hobby to de-stress yourself, turn off all your devices, avoid big meals before go to bed. And adverse life factors, social factors, and the risk factors should be considered and treated accordingly. That's number 1. If insomnia has been identified, medical or psychiatric causes to be ruled out. If specific neurological breathing disorders are suspected, further investigations needs to be addressed. And the muscle tension, like you or most of us feel like the tightness or the spasm, tenderness, and the limited mobility, maybe because of the increased cortisol and inflammation producing these sort of a muscle tension. And headaches are very common because of the stress, lack of sleep, strong smells, and skipping meals. And dizziness, most of the women do get it. Probably you need to take a break, stretch yourself, and do proper exercise as well. This electric shock sensation probably is sharp zaps in the brain and skull, piercing impulses in the neck, burning pains, sharp stabs in the chest, and electric tingling in the limbs as well. And irregular heartbeat, and we know that they do have a tachy or a brady, the rapid heartbeat, dizziness, and shortness of breath, and just discomfort and anxiety. So we know that lifestyle interventions is a must. Encourage to have an optimal blood pressure, pharmacotherapy if the blood pressure is more, use of thiazide diuretics unless there is an absolute contraindication. Women at risk initiate statin, and probably aspirin in a high-risk women to be given. Routine use of aspirin in a woman less than 65 years of age is not recommended. So the hormonal therapy is not indicated solely for the primary or the secondary cardioprotection as well. Coming to the balance, impaired balance in the post-women may be a central effect of estrogen deficiency. Problems with the balance may result in resulting in fractures as well. You know this osteoporotic, the T-score of the normal density is about less than 1, and then we use a HRT or a raloxifene, an active form of vitamin D3 as well. And some of the exercises, probably the easiest main to improve the bone health. And the obesity, people do have a sleep apnea, excessive sweating, shortness of breath, and low self-esteem. And I think it is 1.52 times the metabolic syndrome is more common in women than men. And probably the metabolic syndrome, also known as insulin resistance or a syndrome X, need to be addressed. People do get panic disorders and gum problems like gum injury, gum bleeding, and dry mouth, changes in the state, maybe because of the decreased saliva, increased bone loss as well. So, and again, the digestive problems is very common. Body odor is also very common because it affects the hypothalamus, deregulates the body temperature. And most of us are worried about thinning of hair. Probably we need to go to a stylist, to address these thinning of issues. And again, the itchy skin is very common because we see this sort of hives because of the hormonal fluctuations. And probably, I think we need to avoid the triggers. Probably you take some antihistamines and the lifestyle changes as well. And other problems like hypothyroid, anemia, and probably the blindness needs to be addressed. The breast cancer is probably screening includes the 3 methods of early detection: breast self-examination and clinical breast examination every 3 years. The best way to protect oneself is through a thorough early detection as well. And again, coming to the cervical cancer, is about 25% of the disease burden. Tertiary care liquids, a pap smear, and HPV vaccine plus co-testing has been advised. And the screening recommendations from different organizations like 30 to 65, they say that co-testing with the pap smear with the HPV every 5 years. If pap alone, probably once in 3 years could be done. So coming to this primary prevention, women should be educated early on to think of cervical cancer, and behavioral changes and HPV vaccine is a must. And finally, to talk about the hormonal replacement therapy, you have various types like implants, patches, pills, creams, vaginal rings, and everything. The indications for the hormonal therapy is vasomotor symptoms and genitourinary syndrome of menopause. The treatment should be started as of early to prevent the irreversible atrophic changes, and recurrent attacks of atrophic vaginitis require the use of smallest effective dose. Treatment may be continued indefinitely, although the safety data from studies do not go beyond 1 year. And probably if you're going to use a vaginal estrogen therapy, women with breast cancer, lifestyle management and non-hormonal treatment would be the first option. But in resistant cases, do a joint consultation with the oncologist and the counseling before prescribing these vaginal estrogen. Recurrent urinary tract in this age, after ruling out other causes, may benefit from the local application. And when you talk about the progesterone supplement for the endometrial is not needed along with the use of vaginal estrogen. Low-dose vaginal estrogen formulations reported no incidence of increase in cardiovascular disease or a stroke or a thrombosis. So what are the benefits and the risk of local therapy? Vaginal estrogen therapy is most effective in the treatment of urogenital atrophy. Low-dose vaginal estrogen formulations reported no incidence, as I mentioned earlier. Coming to the androgens, available data of low quality and conflicting regarding the risk of breast cancers. Androgen replacement for use in women is not available in India, but the creams are available. And various regimes, either you have a continuous cyclical regime or a continuous combined regimes are there. The progesterone has been added along with the estrogen in hysterectomy women in case of endometriosis, endometrial ablation, and supracervical hysterectomy. So women with no vasomotor symptoms, it's healthy. Instead, only a preventive care. Whereas women with menopausal symptoms, healthy with vasomotor, probably institute a preventive health care and treat her with hormonal therapy as well. The quality of life, definitely an Indian study has shown an improvement in the quality of life in women receiving Tibolone. Give them an exercise. Physical exercise helps maintain a healthy life. Social interaction is a must. An immunization prescription like hepatitis B and the 2 doses of varicella vaccine has been advised. So problems with women with insomnia, give them gabapentin. With mood disorders, fluoxetine and paroxetine has been advised. Women with dyslipidemia, fluoxetine and citalopram can be given. Tibolone probably is effective in treating VMS and improves the urogenital atrophy. It improves the mood and the libido, and it should be prescribed 1 year after amenorrhea. And the raloxifene probably the best used in a postmenopausal osteoporosis who are at risk of breast cancers of 60 milligram. And finally, to come with the economics of menopausal management, Indian healthcare system is one of the most privatized system where government spends much less. An individual has to spend for health insurance. Under the plan of insurance, many people associate themselves by sharing the risk attached to the individual insurance plan that covers only healthcare costs and is called as health insurance. And you have a two cost because you have a direct and an indirect cost. Most of the companies stop enrollment after 65 to 70 years of age. The direct cost is like physician visit, specialist visit, traditional drug therapy and alternative therapy. The indirect cost, again, the blood tests and others, loss of productivity at home and at work. So the cost of therapy varies according to the indication where they are prescribed prevention or the treatment. So finally, I would say that menopause is a critical window of opportunity for preventing and reducing the risk of cardiovascular disease and maintaining skeletal, muscular, and urogenital health. Lifestyle counseling, smoking cessation, diet modification, physical activity in the menopausal women has to be emphasized. The healthy lifestyle is cost effective. Establishing a menopausal clinics at primary and specialized centers would help in implementing the concept of a critical window of opportunity at menopause. Thank you so much.
Thank you, Dr. Kundavi. It was an excellent presentation. You brought out all the problems in distressing problems in menopause, as well as the solution for it. It was very aptly put about the lifestyle modifications, the exercise, diet. You brought it out very well. And of course, even the hormonal therapy. The next talk will be on, is it thyroid? No? Dana?
Please, Dr.
Yes, yes, Meena, it is on
Thyroid.
thyroid and wellness. Yeah.
Yeah, we all know the importance of thyroid in women's health. The next topic is thyroid and wellness of women in different stages of the life of a woman, be it puberty, menstruation, reproduction, pregnancy, postpartum, as well as in menopause. Thyroid plays a very important role. To talk on it, I invite Dr. Bharat, who's the medical director and consultant endocrinologist in ARCA Center for Hormonal Health. He's graduated undergraduate from Tirunelveli Medical College, did his MD General Medicine in King George Medical University, Lucknow, and DNB Endocrinology in Amrita Institute of Medical Sciences. He's a recipient of Torrent Young Scholar Award and A.V. Gandhi Memorial Award for Best Research Work in Endocrinology. His areas of interest are pediatric and reproductive endocrinology. Over to you, Dr. Bharat.
Thank you, madam. Thank you, Meena, madam, and thank you, Dr. Premlata, madam, for inviting me for this CME on the very important occasion, World Women's Day. I think I can share my slides. Are my slides visible, madam?
Yes, sir. Yes, sir. You have to go.
Thank you, madam.
Yes.
Thank you, madam. And I hope I am audible. So the topic given to me is, I think, a very broad topic, thyroid in wellness of women. And I would say it itself forms a book. Half of our Williams textbook of endocrinology talks about women wellness and thyroid. So it will be hard for me to cover each and every aspect of thyroid in the wellness of women. I would like to just focus certain areas in thyroid physiology. Especially, I don't think that we need to introduce thyroid and what thyroid does to the body to this eminent audience, because we all know that thyroid is a ubiquitous hormone. It's present, its receptors are present all over the body in each and every cell. And the T4, which is released from the thyroid gland, converts into T3 with the usage of an enzyme called a deiodinase. So this T4 to T3 conversion happens at each and every cell, and the T3 gets into the nucleus of each cell and it binds to the receptor, thyroid receptor, which is present in the nucleus of each and every cell. So when the T3 enters in and combines in enters in the nucleus and combines with the thyroid receptors, we can see that the receptors are coded as blue. So the receptors and the subcellular structures, they start working in each and every cell, and the cell specific action starts. Either it is can be in the hypothalamus where it regulates body temperature. It can be in the pancreas where it helps in the development of pancreas and function of pancreas. It can be in the muscle and it improves the energy expenditure. It can be in the liver. It can be in white adipose tissue where it increases the lipolysis and reduces the body fat, or it can be in brown adipose tissue. So these are just some of the areas where thyroid acts, and we know that thyroid acts from head to foot in all the cellular levels. So coming to women and thyroid. Thyroid disorders, when we talk about disorders, it includes autoimmune thyroid disease, goiter, nodule, and thyroid cancer. So among the 4 disorders, autoimmune thyroid disorder is the most common one. And among the autoimmune thyroid disorder, we know that hypothyroidism is the most common autoimmune thyroid disorder. And we have, of course, the other end of spectrum of thyroid disorder, autoimmune disorder, that's called as Graves' disease or hyperthyroidism. The common characteristic of thyroid disorder is female preponderance. And that's one thing I think we'll just discuss in detail. The female to male ratio is reported to be 4 to 6 to 1 for autoimmune thyroid disease and around 4:1 for thyroid nodule. So both for thyroid, autoimmune thyroid disease and thyroid nodule, female are affected more than male. The reason for this problem is why there is a female preponderance. There are several theories which are proposed. The effect of female gonadal hormones and X chromosome inactivation on thyroid gland and immune system. That is a major reason why there is a greater predilection, female predilection for autoimmune thyroid disease. And the hormones which generally act are prolactin and estrogen. And there are several studies which say that the direct action of estrogen on the thyroid tissue contributes to the development of goiter, thyroid nodule, and cancer in women. So just to see how important the X chromosome is. So we know that there are 2 X chromosomes in a female, and X chromosome, when you see the genes which are present in the X chromosome, we know that the X chromosome has a short arm and a long arm. The short arm and long arm of X chromosome has several important genes which are involved in the immune mechanism. So the blue color ones which I am showing are all the genes which are involved in the immune mechanism, and such a in-depth cluster of genes which are involved in the immune mechanism is not seen in any other chromosomes except in X chromosome. So we can understand how important X chromosome is towards it's contributing towards the immunity, and that is the very reason why the problem with the X chromosome happens. That means you get an autoimmune problem. That's the reason why autoimmunity is more common in women. So this is one of the editorial. Actually, it's a X versus X fight that's happening in terms of female cell development. So women have 2 similar X chromosomes, resulting in a double dose of often similar chromosomes among the 1098 genes. So these chromosomes appear to battle it out with the mammalian cells, so which is predominant and actually which has to function. So the loser is inactivated. Whichever chromosome wins among the X and X fight, the loser is inactivated, and this phenomenon is called as X inactivation. So when some of the critical genes which are in the immune system gets inactivated, that causes an abnormal immune mechanism and what we call it as an autoimmunity. So most of the battle of this X chromosome superiority, which X chromosome is superior to over the other, appears to take place in the early embryonic life and results in different cells expressing the paternal or the maternal X chromosomes. So the resulting stable state is inherited through subsequent mitotic cell divisions, resulting in female becoming internal mosaics in addition to the external mosaicism. So there is an external mosaicism happening and there is an internal mosaicism. There is a battle between the one X and another X chromosome. So this is a major reason why there is a high incidence of autoimmunity in female compared to male. So what I am going to discuss now is how to dispel the thyroid myth, because it's not only that we treat a woman with a hypothyroidism with a levothyroxine or a hyperthyroidism with a carbimazole or propylthiouracil. It's very important that women nowadays, because of the influence of social media, because of lots of information which is got from the internet, they are in turn, whoever a woman comes to us with a thyroid problem, they'll always have a lot of questions, a lot of myths they'll be having regarding the thyroid problem. And I think it's our most important thing. Than beyond prescription, we should be able to talk to the patient and dispel at least certain myths which are prevalent in terms of thyroid. Most important myth being, any young lady or any elderly individual comes to me with a thyroid problem, they will generally ask, only middle-aged women will be having thyroid, why I got thyroid? And I generally tell them that from the day one of our birth till around 70, 80 years, thyroid can happen at any particular point of time. This is one of the common myths which is prevalent. Thyroid problems are, the next important myth is thyroid problems are best diagnosed by identifying symptoms. So that's one of the important reasons why we get a recurrent pregnancy loss in several of our women with reproductive age, because they don't have symptoms, they don't check the thyroid. That's another myth which is prevalent. The third myth is it's safe and more natural to treat thyroid disease with iodine or salt. And this is becoming very rampant nowadays, that people start using lots of different kinds of salts when they are diagnosed to have hypothyroidism, and people use non-iodine or low iodine salt, so many kinds of salts. So that's one important myth which we have to discuss with the patient. You can't lose weight with hypothyroidism is another myth, because most of the obesity may not be due to hypothyroidism, which I may be discussing a little bit detail in the latest part. Taking extra thyroid hormone will give you extra energy and make you lose weight. That's also another extreme situation where people take supraphysiological doses of thyroid hormone for losing weight. This is happening mainly in women who are very conscious about their body weight. You can manage hypothyroidism with diet, and if you check YouTube, if you check Google, there are lots of diet which are prescribed for hypothyroidism. N number of questions will be there regarding thyroid and diet. And a lump or nodule in thyroid means you have a thyroid cancer. That's one of the major things which is driving several women to come to consultation. And we know that 90% of the thyroid nodules will be benign, only 10% there is a chance of malignancy. So I'll just go one or two myths how just in detail. The first myth which I am going to discuss is it's safe and more natural to treat a thyroid disease with iodine or salt rather than prescription medicine. So this is one of the important things which is very commonly prevalent myth, is that iodine increases the autoimmunity. And that is the reason many of our women, they start taking low iodized salt or non-iodized salt specifically when they are diagnosed with hypothyroidism. So this is one of the statistics which was published in 2000. The iodine status of India, as we can see, that it comes under the optimum iodine nutrition area. So we don't have an iodine excess, we don't have iodine deficiency also, because most of our areas, maybe some Himalayan belt may be having, but majority of the Indian population, especially we are talking about Chennai population, means we are sitting at the seashore, so we don't have iodine deficiency. That's one part. Second part, are we iodine excess? That is another thing, and definitely that also is not happening, because our fortification of salt is not bringing out that much of iodine so that we become an iodine excess. So iodized salt to take or not to take, that will be a question asked by every woman who comes for a thyroid consultation. And definitely we have to tell them that you have to take iodized salt, and you can take iodine containing natural foods also. So you need not avoid any food, any kind of a iodine food, because you are having hypothyroidism. Of course, iodized salt we tell them to avoid in patients who have a hyperthyroidism, where a low iodine diet is associated with a greater rate of remission of hyperthyroidism. But I am going to mainly discuss about hypothyroidism here. So iodized salt is definitely important in hypothyroidism. You can take iodized salt. But where you have to be careful is that whenever you go for a CT contrast with an iodine agent, beware, because these are the sources. The sources on the right side which I have given are the sources which contain excess iodine. So it's not salt is going to cause a harm. It's that other things, like when you are going for iodinated contrast, when you are going to take more of seaweeds. So generally we don't do that, but some areas, the Southeast Asian countries, they have more intake of seaweeds. People who are on amiodarone, people when they are using topical povidone iodine excess, sometimes especially in elderly individuals who are on a catheter, who are on a bedridden state, they are using povidone iodine a lot, that we can see. especially usage of multivitamins, expectorants, food preservatives, especially used in breads, and some nutritional supplements. These are some of the things which we should be aware of when we talk about the iodine excess condition. So we can take iodine salt, and everyone should be encouraged to take. And we all know very well that iodine is very important for the neurodevelopment of a fetus. So we have seen even pregnant ladies taking non-iodized salt, and that should be definitely discouraged. So the second myth is you can manage hypothyroidism with diet. That's very another important myth. So always the patient will ask is there a thyroid diet? Should I avoid all these things which are seen in this picture? And this is one important thing, probably from where we got the earlier data to say that these things are harmful, the vegetables. See, when we talk about environment and thyroid, there are so many environmental factors which can influence, and there are some studies have been also been done, especially smoking, alcohol, BMI, exercise. These are some of the important things which can influence the thyroid. So if you smoke, you have a chance of getting Graves' disease and hypothyroidism quite high. Alcohol in moderation is okay, not to the extent of toxicity. Higher BMI, higher prevalence of thyroid dysfunction. Lack of physical activity, again, higher prevalence. But when you come to this area of the diet part, again, chemicals are another things which may be environmental pollutants causing hypothyroidism. That's a separately different entity. But here, the brassica vegetables are one thing. People, I've seen women avoiding brassica vegetables for several decades. Once they are diagnosed with hypothyroidism in their early 20s, they come to us at 60 years asking that I have avoided the cabbage for 40 years, still my thyroid is not cured. And probably that is one thing which we have to, a myth which is, we have to give a scientific evidence saying that there is no data to say that usage of cabbage, cauliflower, broccoli, or turnip, or soy products, or caffeine or tea consumption has been shown to increase the occurrence of goiter, hypothyroidism, or thyroid cancer. So this is one thing. Of course, we advise low iodine salt only in hyperthyroid women. We don't advise a low iodine salt even for a pregnant lady who has a hyperthyroidism. So only a very special situation where low iodine is recommended, and not beyond that extent. And all our thyroid patients can take a balanced diet containing all sorts of vegetables, fruits. They can take coffee, tea. Nothing has to be avoided. Again, talking about thyroid wellness in women. So thyroid in adolescence, fertility, obesity, old age, these are some of the areas where some gray areas are still prevalent. And I am going to mainly focus on the subclinical hypothyroidism part, because we know that this area of the hypothyroidism, the frank hypothyroidism, we always treat with levothyroxine. And this area, the hyperthyroid part, generally endocrinologist help is sought. But this area is where women generally go to gynecologists for their opinion, and they are in a position to clarify so many things for the women. And here I am going to focus mainly on these four aspects. So thyroid disease among teens, what happens? Suppose we find a TSH of 6 or 7 in a child, in an adolescent girl with hypothyroidism, adolescent girl coming to us for the management of obesity. What's going to happen? How are we going to treat it or not is a question. So what happens to the natural history of subclinical hypothyroidism in a child or adolescent? We can see these are some of the data. I'm not going to in detail about the data. We can see that the right side 2 columns, the rate of persistence of subclinical hypothyroidism happens in 65%, reversion happens in 20 to 30%, and progression to overt hypothyroidism happens in another 20 to 30%. So 50% around population of subclinical hypothyroidism girls, they stay in the same subclinical hypothyroidism. Around 20% go to a normal thyroid function, even if you don't treat them. And around 20 to 25% can progress to overt hypothyroidism. That means their TSH may increase if you carefully follow them up. So it's not that all girls who have a TSH of 7, 6 has to be treated, but we should identify who are having a risk factor for progressing to a overt hypothyroidism from a subclinical hypothyroidism. Here again comes the female gender. As we have already discussed, the X chromosome, which is playing a major role in autoimmunity. So if a girl is having hypothyroidism, subclinical hypothyroidism, follow them up carefully so that the chance of going into a overt hypothyroidism is more for them. When the TSH is high, that means If the TSH is 8, the chance of going into overt hypothyroidism is high compared to a TSH of 6. A positive family history of autoimmune disease. This is where history is important. So a thorough family history of autoimmune disorder has to be taken, including the presence of vitiligo or other autoimmune disorders. Positive anti-TPO antibodies. And here comes that in adolescents, whenever we see a TSH of 6, get an antibody level done so that we will assess the risk of progression to overt hypothyroidism and presence of goiter. So if a girl has any of these risk factors, then the chance of going into overt hypothyroidism is high. And always a TSH between 4 and 10 or 5 and 10 should be repeated after 4 to 6 weeks or after 2 to 3 months. And if the TSH is persistently increasing, or if the patient has any of the risk factors, then there is a point in treating them with levothyroxine. Otherwise, if a TSH is stable, close follow-up is only recommended and no need of treatment in a girl child with a subclinical hypothyroidism. But we should always remember that if a girl is having autoimmune thyroid disorder, it may not stop with the thyroid alone. Sometimes it may involve other glands. The girl may land up with a premature menopause at 20 years of age. She may come up with a secondary amenorrhea. The girl may also have a primary amenorrhea because of Turner syndrome, because autoimmune polyglandular syndrome, Turner syndrome have a higher incidence of hypothyroidism. So if a girl has some other symptom related to thyroid, we have to check other hormones also to rule out autoimmune polyglandular syndrome. And always in a type 1 diabetes girl, autoimmune thyroid disorder has to be checked, and every year the follow-up has to be done. Coming to obesity and thyroid, this is another important aspect, because many of our women who are overweight or obese attribute that to their thyroid function, and they are relatively sedentary in their lifestyle. So they always tell that, no, because of thyroid, I will not be able to lose weight. That's one common myth which is prevalent now. Thyroid can increase the weight by altering the adipogenesis, by increasing the adipocytokine levels. That's one thing. But the weight gain may not be around 3 or 4, beyond 3 or 4 kgs, and that too in uncontrolled hypothyroidism. So when we are going to treat the lady with a thyroid hormone replacement, definitely the 3-4 kgs weight gain will be revert to normal. So a patient may not become from 60 to 80 kgs just because of thyroid alone. And this is one of the important things that we have to talk to the patient. And this editorial we published around 14 years back when I was a resident in Amrita Institute along with my professors Jayakumar sir and Unikrishan sir. And we noted that it's not that thyroid is causing obesity, it's the obesity which is increasing the TSH value. Because obesity itself has hypothalamic dysfunction and there is a high leptin levels in obesity. So what happens is that in obese individuals, we may see a high TSH like 6 or 7, they may not have autoimmune disorder. And if you treat the obesity, if the patient loses weight, the TSH also falls to normal range. So weight loss is the only treatment for this high TSH and not replacing them with a levothyroxine. Again, thyroid and female infertility is one of the fantastic topic which is discussed in each and every CME, 2.5, 4.5 TSH cutoff, all these things, I think they are discussed threadbare in all the CMEs. I'm just going to give 2 important publications which have been done in 2021. Probably we are coming through full circle. This publication is a very good publication. It's showing the impact of preconceptional TSH value ranging between 2.5 and 4.5 on live birth rate following ovulation induction and intrauterine insemination treatment in unexplained infertility. So what they have done is that they have just kept some women the TSH value below 2.5 and some women have a TSH value between 2.5 to 4.5, and they underwent ovulation induction and they underwent the artificial reproductive techniques, and we can find that a value of less than 2.5 or 2.5 to 4.5, there was no difference in the outcome. We can see that the p-values in the right side are all insignificant. So in terms of live birth, in terms of miscarriage, in terms of number of follicles, in terms of ovulation induction duration, there is no change if you are keeping the TSH below 2.5 or below 4.5. So in euthyroid women undergoing ovulation induction with gonadotropins and IUI of unexplained infertility, range of preconceptional TSH between 2.5 and 4.5 is not associated with the lower pregnancy rate when compared to TSH of between 0.3 and 2.5. So up to 4.5 is okay according to this paper. Again, there is another paper which was again published in 2021. Probably COVID has given adequate time for us to think about the fertility issues also in thyroid. here what they have done is they have treated a subfertile women in terms of a primary subfertility or secondary subfertility. So they have categorized the women based on the TSH value. That is, women with a TSH of less than 1.3, 1.2 to 2.7, 1.2 to 1.7, 1.7 to 2.5, and 2.5 to 4.5 again. And we can see that the live birth rate improves when the TSH is kept on the lower side, whereas when the live birth rate is little less, when the TSH is at 2.5 to 4.5. This is in a primary subfertility. But what they have found out is that when you combine the primary and secondary subfertility, the high normal TSH is not associated with adverse implications. And it is therefore possible that minor changes in the thyroid status may not be associated with fertility outcomes. However, higher TSH are associated with primary subfertility. So women who have a primary subfertility, there is a point in treating them to keep the TSH below 2.5. But in terms of secondary subfertility, we have to reconsider whether keeping a TSH at 3 or 3.5 is okay or not, because we have two data which have come out 2021. Probably we need more trials, prospective trials in Indian patients. So this is a gray area again. It's becoming gray area now. Again, thyroid dysfunction in old age is another important thing. See, as age increases, the TSH cutoffs also move physiologically to the upper limit. So at 90 years of age, a TSH value of even 7, or I would say 8 or 9 is also okay for these individuals. And we need not get panicked just because the TSH comes to 6.5 or 7 for an 80-year-old woman. So that is one important thing. And the guidelines clearly state that even at 65 to 70 years of age, if you have a TSH of 6 to 10, either you have an option of either observe or you have an option of treatment. It's not that you have to only treat all these individuals below 10. And if you see a frail patient, a patient who is under the care of someone else in a home care facility or something, don't treat those women even if you show a TSH value of up to 10. So only observation. And only at 65 to 75 years of age, there is you can give a trial of treatment if the TSH is more than 10. So at 75 years of age, more and above, if a frail woman comes to us who have a TSH of more than 10, treating them may not be a prudent option, because treating them and keeping the TSH at a lower level like 2 or 3 is going to cause them more harm in terms of cardiovascular, in terms of bone issues, rather than not treating them. So whenever we get a woman, a 65, 70-year-old woman with a TSH of around 10, always you can repeat the test at 3 to 6 months interval. Even if you want to treat with a very smaller dose, maybe less than 50% dose. And no need to keep the TSH at 3 or 4 in those women. It's better to keep the TSH at 6 or 7 so that we don't increase their mortality. So the message which I want to give is, priority shall be given to the clinical endpoints rather than absolute numbers. So all the CMEs, we talk about the numbers in TSH, 2.5 or 3.5 or 4.5. Probably we have to look beyond that, but we don't have still clinical data, very robust data. So till we get a good clinical data, we need to depend on these numbers. But especially in adolescence, infertility, obesity and all, we need not treat them with a mild TSH elevations. And many times, women come to us with unrealistic expectations, saying that if we treat a TSH of say 5.5 or 6 with thyroxine, their hair loss will improve, their mood swings will improve, their tiredness will improve, and all the perimenopausal symptoms will be gone. But that won't happen even if we treat them for 1 year or 2 years, and they will be coming back to us repeatedly asking that even after treating with thyroid, my symptoms have not improved. So the expectation, what the patient has come for us, and what is the reality, what is the realistic goal, is one thing which we always have to discuss with the patient while starting treatment with the levothyroxine in these individuals. And again, whenever a woman with a reproductive age group comes and asks us about the diet and thyroid and the iodine intake and thyroid, it's a very clear statement that there is no specific diet for thyroid. Iodine intake has to be in the proper way in terms of iodized salt, and no role of non-iodized salt or a low iodine salt in those. Thank you very much for the opportunity given to me, and I would like to answer any questions or share your experience also in terms of thyroid and women wellness. Thank you.
A very lucid lecture, sir, on all the aspects of thyroid dysfunction, especially in the older woman. And it is very, very good to know that we should not jump and start treating women in the very older age group. The one group which you have not talked about is the pregnant women.
Yeah,
So,
because that's a big topic. And 20 minutes.
Hypothyroid.
Yeah.
My only question would be, sir, that we take 4 as a cutoff when we don't have standards, yes. But if we have an overt hypothyroid woman presenting to us directly for the first time, many times we send them to our physician colleagues and they start with very low dose of thyroxine. So is it okay if the first trimester we are concerned that how would you start and how would you increase how often and how much would you increase the increment of thyroxine?
See, if suppose there may be 3 situations where one is a woman who is already on a stable thyroid dose becomes pregnant. Second is a woman who is coming for the first time during pregnancy in the first trimester and we detect a TSH value. We get a TSH value of 5 or 6. And third thing is already a patient who is under good control of thyroid. That's a different thing. So here, if suppose, for example, if a woman comes to us saying that TSH value is 15 or 20, sometimes we get even very high values of TSH detected for the first time during pregnancy. Ideally, it's better to start a full dose of levothyroxine for them. And rather than starting with a 25 milligram dose or 50 milligram dose, they might require even 75 or 100 milligram dose. Always what I do is start with a dose which is appropriate for the body weight. Say 1.5 to 2 microgram per kg body weight is a usual thyroid dose requirement. Suppose a 50 kg woman comes to us with a TSH value of 12 or 14 or 15, we can always start them with 75 micrograms or even with 100 micrograms. But what we have to do is take a TSH at 4 weeks interval, at 1 month interval, see the drop in the TSH value. Suppose the drop is very drastic, say from 12, the TSH has dropped to 1 in the next 1 month, for example. That means the drop is a little bit more drastic in the next 1 month. So what we can do is that we can do a minor dose reduction, not a very major dose. Maybe from 100, we can come to 88 micrograms for them, for example. So a careful follow-up will definitely give us an answer. And there is no harm in treating the women with the appropriate dose of levothyroxine at 75 or 100 micrograms. There is no need to treat them with 12.5 or 25 micrograms unless the woman is grossly underweight.
Thank you very much, sir.
You can introduce Meena. You can introduce next speaker. You are muted.
Can we have the slide? The next speaker.
Can I share the slides, ma'am?
No, your the introduction slide.
I will be first showing my introduction slides as well,
yeah,
ma'am.
Please. Yeah, the next speaker, the topic is Embarrassing Galactorrhea by Dr. Deepa Thangamani. She's the consultant in Apollo First Med Hospitals and consultant in Tamarai Fertility Solutions. And she's currently the Joint Secretary, the Association of Tamil Nadu Members of Royal College of Obstetricians and Gynecology, and the Joint Secretary of Chennai Menopause Society. I think she's her achievements are, I think you can see in the slide itself, there are a lot. Her areas of interest are gynec endoscopy.
Okay, ma'am. Sorry, ma'am.
Over to you.
Thank you, ma'am. Thanks for the kind introduction, madam. And at the outset, I'd like to thank Premlata madam as well as Dana madam and the whole Oxy team for giving me this opportunity. And my topic is an embarrassing galactorrhea. So galactorrhea, if the definition is like you saw a blood, you saw a nipple discharge, other than the physiological conditions like pregnancy and lactation. Other than that, if you see any discharge from breast, then we'll be worried. That is, it is inappropriate, persistent, excessive. It is defined as a galactorrhea. And the main worry for the women who are not pregnant, who are not lactations and presented with, the main concern is cancer. So we have to reassure them. See, if we have a multi-duct openings and both the breast white and clear liquid, sometimes yellow, green, brown discharge, they are safe. There is nothing to worry. Maybe probably there will be an underlying causes we need to find out. If it is a bloody or single duct, then it should be a cancerous. So rule out the physiological and diagnosis, it's a galactorrhea. When you diagnose galactorrhea, is the quantity of secretion is an important? No, it is not an important criteria. So the galactorrhea can be spontaneous or only while stimulating the breast or nipple stimulation when pressing, then you will be find out, or it can be spontaneous. So how will you elicit in clinical? The same things like how you will be expressing a milk. Start from the base of the breast and go towards the nipple, and just if you demonstrate the white and clear liquid, then it is we diagnose that as a galactorrhea. So what is the cause for this galactorrhea? We know this hormone prolactin is a polypeptide. So this is a prolactin hormone is secreted from the anterior pituitary from the basophilic cells, and it is counterpart is a growth hormone. So prolactin, growth hormone, and one from the placenta is the human placental lactogens. All shares the same ancestral proteins, polypeptide. So when the prolactin secreted from the anterior pituitary act on the breast, we need estrogen and progesterone should be primed the breast. So what is the role of estrogen? The role of estrogen is like improve the duct nipple, increase the size of the nipple ducts, and progesterone's formation of the alveoli, and the prolactin in the alveoli started secreting the milk secretions. And once the baby sucks, oxytocin reflex comes and the milk is letting out. Later on, all the hormones will be normal. Even then, the spontaneous milk secretion will form. Okay, so this exactly that alveolar milk secreting epithelial cells and adjacent myoepithelial cells and the blood vessels and the main lobular duct. Okay, so it is synthesis from antipulsatile, pulsatile. In endocrinology, two things when importance. When it is a pulsatile, so you will be having an increased secretions. When it is a continuous secretion, then the hormone will be inhibited. So prolactin as well as have a diurnal variation. The peak level happen in the morning 5 to 7 a.m. So don't do the blood test in the morning 5 to 7 a.m. Do it in the, it is lowest in the mid morning. So later half of the morning in the fasting sample, you do a blood test. So when to investigate? So normally galactorrhea, if it is a bothersome or when to investigate? In a nulliparous woman, yes, you have to investigate. In a pregnancy, the radical duration they have given is 12 months post-pregnancy and 12 months post-weaning. But we all know this recommendations is empirically we all know that the persistent galactorrhea for many months after breastfeeding, and therefore there is a room of clinical judgment. If you really needed that lady has to be evaluated, please evaluate and causes. This is actually a clinical complex clinical challenge. So because there is a three routes we have to follow. One is like the problem in the hypothalamus. One is the problem is an anterior pituitary where the prolactin is secreting, which has an dopamine have an inhibitory effect, which is released from the hypothalamus, and thyrotropin releasing hormones and vasoactive inhibitory peptide from the hypothalamus have a stimulating effect. But the thyrotropin releasing has a transient effect, and it comes to the circulation and cleared by the renal. So any problem in the systemic renal clearance, then you will be having a hyperplatinemia. The drugs, psychotic drugs will act on the dopamine receptors, and any tumors in the stalks, hypothalamus, as well as the anterior pituitary, and non-hormone secreting tumor also have a elevation of the hyperprolactinemia. So it is a complex clinical challenge. Prolactin causes increased prolactin causes galactorrhea, and inappropriate. Ultimately, the end result is an inappropriate increase in the prolactin release. So what is a normal level of prolactin? Up to 20 nanogram is a normal release. So when you see more than 20 nanogram, your first most priority is you rule out hypothyroidism. Why? Increased thyroid in the thyroxine in the general circulations increases the thyrotropin releasing hormone from the hypothalamus, which increases the TSH, which is released from the basophilic cells of again the anterior pituitary and normalizes the thyroid. So the same TRH, as I already said, is a prolactin releasing factors which releases the prolactin from the pituitary. So if you reverse that with the thyroid hormone, most of the times the prolactin levels secreted. So the first and foremost, you rule out thyroid. Second, we know the commonest causes the brain, the most commonest thing is brain, and most dangerous things we have to rule out. So what problems in the pituitaries, non-pituitary tumors, non-functional pituitary tumors, and hypothalamic stalk lesions, stalk compressions. Events that physically reduce the production and delivery dopamine. Dopamine has a nickname, is a prolactin inhibitory hormone. So when the dopamine is reduced, the hyperprolactinemia happens. So which causes galactorrhea. The third most commonest condition causes is the drugs. How the drugs affects the role in the problem? It has a direct effect of dopamine inhibition in the hypothalamus and deplete the dopamine levels and blockade the peripheral levels in the anterior pituitary lactographs, the dopamine receptors it will block. The common clinical chemical features in many of these drugs, whether it is antipsychotic, antidepressant, and prokinetic drugs, the commonest features is have an aromatic ring with the polar substitution as in estrogen. Estrogen, which increases the prolactin. So prolactin is uniformly elevated in those have got drugs which is causing hyperprolactinemia, even in the therapeutic amounts of these drugs, but essentially it never been as high as 100 micrograms, more than 20, less than 100 in drug-related, drug-induced hyperprolactinemia. Approximately 30 to 50% exhibit galactorrhea should not persist. Once you stop this withdrawal, the galactorrhea will be started reducing in within 3 to 6 months of discontinuing the drug treatments. These are the commonest drugs. So antipsychotics, if you take it out, it's an older generation antipsychotics typically causes hyperprolactinemia. And when the newer generation comes, very rarely the aripiprazole causes hyperprolactinemia. Antidepressant, your tricyclic, your SSRI, SNRI, and monoamine oxidase inhibitors, your antihypertensive drugs like methyldopa, verapamil, lebitalol, rezapine, your prokinetic agents, metoclopramide, domperidone, your H2 receptor blocking agents, cimetidine, ranitidine, and estrogens, anesthetic drugs, opiates, your mood elevating, cocaine, marijuana, alcohol abuse, all causes increases the dopamine, which inhibit the dopamine, which causes high prolactin levels. So the treatment is, one is, if possible, you can remove the drug withdrawal. With drug withdrawal, within 3 to 6 months, you reassure the woman that problem will settle on its own. But if the drug withdrawal is not possible, and the woman is embarrassing, the galactorrhea is embarrassing or very much bothersome, then you can use a dopamine agonist. Dopamine agonist, the problem is antipsychotic. Sometimes the psychosis will be increased when you introduce a dopamine agonist. So only with antipsychotics, a little bit careful when you introduce a dopamine agonist as a treatment. Otherwise, you can treat the dopamine agonist for a short term or long term, as long as it is needed, as long as the patients clinically needed. Okay, so estrogens, either direct hypothalamic suppression and acting on the pituitary lactotrophs, it increases the prolactin. And common thing is sucking. Prolonged sucking inhibit the dopamine at the hypothalamus level. The same things, your thoracotomy scar, post-CABG, cervical spinal lesions, eczema, herpes zoster. It causes that afferent sensory neural axis is activated. Thereby, it simulates the sucking and increases the prolactin release. Stress, again, hypothalamic dopamine is inhibited. Your trauma, any surgical procedures, anesthesia increases the stress levels. What are the non-pituitary sources? You have decreased clearance in renal, CKD, and liver, whereby the prolactin is not excreted into the metabolized and excreted into the urine and settled in the circulating level, or any lung tumors, ovarian tumors, renal tumors, and very rarely uterine leiomyoma, which increases the. What about the PCOD? So we all think PCOS and hyperprolactinemia is all interlinked, but it is actually a myth rather than a well-established reality. So that logically, that before the introduction of the Rotterdam criteria in 2000, in 1980s, they all described hyperprolactinemia in 7% of women with PCOS. But the theory they have mentioned, the theory they mention is because of the relating hyperestrogenemia, and there is a common hypothalamic pituitary abnormality in PCOD as well as hyperprolactinemia. But what they found out is that there is no link of the elevation. If there is a prolactin elevation in PCOS patient, then you have to evaluate prolactin as per how you evaluate hyperprolactinemia. And sometimes the macroprolactinemia, which I discuss later, and pituitary microadenoma, very, very small size, not detectable in imaging, to be considered in a woman with PCOD with high prolactin. And finally, there are two causes like idiopathic. When you don't have any other reasons, then we put them as an idiopathic. But even when you put them as an idiopathic, that naturally they won't be an idiopathic. That will be over the times they develop some kind of probably that pituitary microadenoma less than 3 millimeter cannot be detected, can be over the times if evaluate as a macroadenoma, or hypothalamic pituitary dysfunction and dopamine receptor problems will comes later on as an idiopathic. So, and macroprolactinemia. So what is macroprolactinemia? It is to discuss the macroprolactinemia, we'll go to the basic. There are 3 prolactin serum isomers. One is which is a tiny prolactin, which is monomeric prolactin, which is 80 to 95% of prolactin we have tested in the immunoassay is this prolactin, which is a low molecular weight. And again, second is a big prolactin, and third is a big prolactin, which is more than 150 kilodaltons, is still 10% of hyperprolactinemia. This is a reason. Why it is called macroprolactin? The same monomeric little prolactin is formed a complex between IgG. It is like an autoantibodies to the prolactin, which make that prolactin is a bigger prolactin. So this, mostly macroprolactin, the condition is termed macroprolactin. Most of the times, this bigger prolactin doesn't cause any symptoms. Rather, other than IgG, it can also have a complex with IgN, IgB, IgM, or some glycosylated monomeric prolactin will form as a macroprolactin, and covalent and non-covalent aggregates of the same tiny prolactins have rarely been demonstrated and formed as a macroprolactin. Macroprolactin, though it says no symptoms, it causes 26% of the times it will cause menstrual disorders like late follicular issues and irregular anovulation, irregular cycles, delayed cycles with heavy flow. And finally, if there is a very, very high prolactin, it causes amenorrhea, hypogonadisms. And 13% of times it have an isolated galactorrhea. And 3% of times it have both galactorrhea and menstrual disorders in macroprolactinemia. So in macroprolactinemia, this cannot be detected in the normal immunoassay. Only tiny prolactin we can detect. So galactorrhea with a normal prolactin levels, we have to suspect macroprolactinemia. So when you consider the total cause of elevated prolactin levels, the tumors come in the first stage. This is a Brazilian multicentric study. Idiopathic comes around 3.6, and your macroprolactinemia comes in the third, 9.3% next to the drugs. Second commonest cause for hyperprolactinemia is the drugs, and third is your macroprolactinemia. Next comes your hypothyroidism and your idiopathic. So how to do a prolactin lab test? As I already said, you can do it in the late in the morning in fasting after 60 minutes of rest, not in late follicular phase. Repeat the sample if one sample is raised, and avoid sex or nipple stimulation. If you examine your patient, don't do it the next day. Do it a little later on. So when it is elevated, repeat the sample. If again is raised, then check your thyroid and creatinine to look for renal clearance and thyroid for hypothyroidism. If anything, you treat it. If there is a symptoms of hypogonadism, irregular cycles, anovulation, check your FSH, LH, estrogen. If severe hypogonadism causing infertility and amenorrhea, then go for DEXA scan to look for osteoporosis. And if there is if everything else is normal, go for an MRI, or if they have a visual field test, look for any problem in the vision, tumor compression. This is when you say the tumor, you have to look, you have to consider what hook effect. What is hook effect? So when you expect a large pituitary adenoma more than 3 centimeters, the expectation of the prolactin level is more than 1000, around more than 500 to 1000. But if you say normal and only mildly elevated prolactin levels, then the hook effect is suspected, because you have so much of prolactin, but when you tested, you put an antibodies to test this, agglutination to test this. So you don't have much of antibody to test this so much of antibodies. That's the reason your prolactin levels you cannot able to pick up. So you dilute this blood and then to redo the test, and you will find out the real prolactin levels. So when you find out the prolactinoma and your normal prolactin, then suspect the hook effect. So this is how the normal usual prolactin range. In your drug-induced and hypothyroidism, macroprolactinemia, your prolactin never goes beyond hundreds. But these are some of the exceptional cases where sometimes it will be high. And your macroprolactinemia, as I said, if it is a cystic macroprolactinemia due to hook effect, sometimes the prolactin levels will be less. So non-functioning pituitary adenoma like craniopharyngioma, stalk tumors, it will be still less. And microprolactinoma less than 3 centimeters, you have at 100 to 250. So how will you evaluate? Nipple discharge, the first and foremost, you have to make them understand that it is not cancer, rule out a cancer. Look at history, examinations, FNAC, if bloody discharge or mammography. Then consider that as a galactorrhea. They look for elevated prolactin levels. If there is no elevated prolactinuria, this is a galactorrhea with normal prolactin levels, then there is actually don't do any evaluation, stop with this. And if it is not embarrassing, tell them no treatment is needed. But if it is embarrassing or bothersome, treatment with dopamine agonist if the woman complains. If there is an elevated prolactin levels, your rule is like rule out thyroid, you rule out pregnancy, rule out drug-induced, rule out renal clearance. If there is no cause identified, next option is your MRI. And if it is a normal MRI, you consider as idiopathic. Idiopathic can anytime go into tumor or anytime go into macroprolactinemia. So either no treatment, or if it is a bothersome galactorrhea with idiopathic hyperprolactinemia, then go for dopamine agonist. And the final is like cellular, if MRI brain says any cellular or supracellular lesions, either you go with a dopamine or surgery. And these are the two drugs that the gynecologist knows. One is a bromocriptine and cabergoline. Cabergoline is the most commonest used by the gynecologist now. Bromocriptine, yes, some women, if they are planning pregnancy for ovulation, before ovulation inductions with hyperprolactinemia, for the safety purposes they are using, but for the last 10 years, the safety of cabergoline has also increased. Start with either with a low dose or high dose, depending upon the prolactin level, how they are responding. 0.5 milligram once weekly, and slowly reduce to once the response has been response, the patient is responded, prolactin level start decreasing, don't stop abruptly, reduce to 0.5 milligram twice weekly, and then slowly taper it. So all the side effects will be there with bromocriptine and cabergoline. Cabergoline has a less side effect. The one problem with the cabergoline is like high dose of cabergoline have a cardiac valvulopathy. That you have to consider. And this is the drugs most commonly, the quinogolide. It is also a dopamine agonist used mostly by the neurosurgeon as well as the endocrinologist. The dose is 25 microgram to 75 microgram. Has a high affinity for dopamine receptors. It's a tumor-resistant bromocriptine that have responded to this drugs. So as I said, that for a galactorrhea woman with a normal prolactin, you have to suspect macroprolactinemia, and 40 to 50% of times without macroprolactinemia, they will be having a normal prolactin because the bioactive of the prolactin will cause us a galactorrhea. But what we are checking is a immunoreactivity because of so much of structural variants available. Sometimes the assay circulating levels, we can't be clearly detected. So 40-50% of times galactorrhea patient will be having normal prolactin. So even then, if it is asymptomatic, treat with dopamine agonist, they will respond. Periodic fluctuation and sleep requirements causes normal prolactin. As I said, biopsy, sometimes the earlier episode of hyperprolactin, which triggered persistent galactorrhea. And this is a condition, they will be hyperprolactinemia, but not necessarily a galactorrhea is a must. So 60 to 65% of times, they must be having some other symptoms like hypogonadism, amenorrhea, irregular cycles, and brain issues, headache. So they have, So that baby, because I already said the prolactin, if it is amenorrheic patient, there is no estrogen progestin priming of the breast. So prolactin can't act, so there won't be any galactorrhea. That was the reasons. High prolactin does not interact with the breast receptors if it is not primed by the estrogen and progesterone. So menstrual irregularities, if it is a mild hyperprolactinemia, it causes delayed follicular growth. And moderate, it causes anovulation, irregular cycles, and high prolactin, infertility, amenorrhea, hypogonadisms. So once hypogonadism is treated, the DNRH inhibition reflected, they will ovulate. You can simultaneously use other ovulation induction drugs. And the most take-home message I will say is a screening for macroprolactin. When you suspect there is an idiopathic hyperprolactinemia, galactoria with a normal prolactin levels, if there is persistently, it's a bothersome continue even after dopamine agonist, atypical clinical picture, delayed decline of serum prolactin levels. When you use a dopamine agonist, you cannot able to stop, reduce the dopamine. Sometimes you will stop it, and they will repeat, will go back to the high prolactin level. So in that conditions, you can screen it. So this is having a low clearance, so it stays in the circulation for longer times. It cannot be, since it is a big, it cannot go through the renal clearance, longer half-life and lower capability to activate the hypothalamic dopaminergic actions. The gold standard for checking that macroprolactin is by gel filtration chromatography, but it is very expensive. Polyethylene glycol serum precipitation is another method which is commonly used. So take home, treat the cause, drug withdrawal if possible, and very careful with the dopamine agonist with the antipsychotics. If woman doesn't desire pregnancy, you can use other methods. Infertility is a concern, then you have to use dopamine agonist and ovulation induction. Microdynamo, your dopamine agonist shrinks tumors, treat the galactoria, and menses will resume. Macro, it's long-term dopamine agonist is needed. Surgery if there is no response to medical treatment or if you have a vesical field defects. So treatment practice guideline, treatment is not recommended asymptomatic macroprolactinemia. So normoprolactinemic galacturia, no further evaluation is needed. In case of hyperprolactinemia cannot be found by history, examination, routine lab testing, then as I said, some routine MRI may miss. So you have to go for a specific pituitary cuts and intravenous contrast study to look for any less than 3 millimeter tumors. Treatment of hyperprolactinemia should be targeted primarily to correct the cause. Treatment of hypothyroidism, replacement or discontinuation of offending drug. Thank you.
Very, very comprehensively covered, Dr. Deepa. Congratulations.
Thanks.
Very, very informative and exhaustively covered, I must say.
When are we taking end? We are taking the questions, huh? Any questions in the chat box?
In the chat box, I can't see any questions, madam.
Can we move to the next topic now?
Yes, pa.
We go to the last very important topic, irritating leukorrhea, a focus on bacterial vaginosis by Dr. Tamil Kodai.
Yes, ma'am.
Dr.
Good evening,
Tamil
all of you.
Kodai is a professor in Tirunelveli Medical College. She did her UG from Tirunelveli Medical College, MDOG from Stanley Medical College. She's a teacher for the past from 2002. Over to Dr. Tamil Kodai.
Thank you, ma'am, for the nice introduction. Shall I share my screen?
Yeah.
Can you see now?
No, ma.
Not yet.
Not shared.
Okay, okay.
Because you put share screen, you put your button on. Open your PowerPoint, ma. Yeah, it's coming.
We can see your slides, madam.
Yes.
I cannot see the next slide. Okay, okay. Yes, ma'am. Good evening, all of you. Today, my topic is bacterial vaginosis. And the irritating leukorrhea was the main topic given to me, but the focus is on bacterial vaginosis. Leukorrhea is excessive vaginal discharge, which is called as leukorrhea, and physiological causes are, that is, increased normal vaginal secretion is called as leukorrhea. Cervical leukorrhea is due to increased secretion from the endocervical gland, and the vaginal leukorrhea is due to transudation. It is only a transudation from the vaginal walls. And physiological leukorrhea occurs during ovulation, during premenstrual period, during intercourse, during pregnancy, and during puerperium. And the pathological leukorrhea, it is mainly due to vaginitis. The three main infections are bacterial vaginosis, Trichomonas vaginitis, and fungal vaginitis. Then sexually transmitted infections, cervicitis, pelvic organ prolapse, foreign body in the vagina, and carcinoma cervix. These constitute the pathological causes. And then the genital causes, they contribute 2/3 of the total causes. And the vulval causes contributes 1%, that is growth and ulcers in the vulva. Vaginal causes at 20%, gonorrheal, monilial, and trichomonas vaginitis. Then the cervical causes contributes 28%. They are due to chronic cervicitis, erosion, carcinoma cervix, and post-abortal puerperal periods also constitute due to lochia and infected lochia. And then the general causes for the pathological leukorrhea are undernutrition and ill health of the patient. And then anemia, liver dysfunction, chronic colitis, chronic constipation. And what are all the causes which leads on to pelvic congestion? They leads on to leukorrhea, that is pathological leukorrhea as well as physiological leukorrhea. Then you should know the defense mechanism of the reproductive tract. This is the basic one. And in the vulva, the apposition of the labia, they prevents, that is a defense mechanism. And the apocrine gland secretion, they constitute fungicidal action. The secretion is a fungicidal one. Then the vagina, the apposition of the anterior and posterior vaginal walls, the transverse rugae in the vagina, and the stratified squamous epithelium devoid of glands. So they constitute the defense. And then the glycogen in the vaginal wall, the action of Dodderlin's bacillus on the glycogen, they produce lactic acid, that is the acidic environment inside the vagina, that is 4 to 4.5. Some book says 3.5 to 4.5. So this acidic environment is very important. And then the cervical causes, it is narrow cervical canal and the racemose glands inside the cervix and the mucus plug inside the cervical canal and the lysosome and IgA factor inside the cervical secretions. They are all locally defense mechanism, locally effective protective mechanisms for against the infections. And then the tubal causes are tubal peristalsis and ciliary movements of the ciliated epithelium of the tubes towards the uterine cavity. So towards the uterine cavity, the motion, which is a defense mechanism. And then the history, as usual, you should ask the age, marital status, parity of the patient, history of present illness regarding the characteristic of vaginal discharge, itching, etc. And then the duration and relation to menstruation is very important because the menstruation, which leads on to the alkaline pH, then the vulval irritation, the itching and burning, then menstrual history, sexual history, obstetric history, contraceptive history, and the past illness like TB, diabetes, etc. And then the clinical examination is mainly the general examination, which 1/3 causes, they leads on to vaginal secretions, increased vaginal secretions. And then the speculum examination is utmost necessary, and then bimanual pelvic examination. Then the vaginal discharge, based on the characteristics of the discharge, the stage of life before puberty, the causes are foreign body in the vagina, the pathology is vulvovaginitis, and the characteristic of discharge is mucopurulent. Then after puberty, the causes are anemia, colitis, and poor hygiene. And then the pathology is mild vaginitis. The characteristics are thin and watery secretions. And then the nulliparous married women, the causes are infections and the retained IUCDs, tampons, and oral pills. The pathology is vaginitis, cervicitis, Bartholinitis, and tears of the cervix and vagina. The characteristics of discharge are profuse mucopurulent. And then the post-childbirth, the hormonal changes will be there. The pathology is physiological erosion due to the pouting of the cervix, and then the discharge is mucoid and watery. The Paris women, the causes are anemia. The pathology is increased epithelial permeability, and the characteristics of discharge are mucoid or mucopurulent. The premenopausal women, they are having the benign lesions like polyps, fibroid uterus, prolapse, and carcinoma, and malignant lesions like carcinoma. And the pathology is increased congestion due to the benign lesions. The discharge characteristics are mucoid and blood-stained. In postmenopausal women, the pathology is mainly cancer, senile vaginitis, senile cervicitis, endometritis. The characteristics are blood-stained and mucopurulent. Then the treatment for leukorrhea is, it is based on the pathology, we should treat the cause. And the cervical factors, along with the course of antibiotic, that is cauterization, electro and cryocauteries. Then the pelvic lesions, the appropriate therapy for according to the lesions. And then the bacterial vaginosis, this is my focus. And the patients will come with their hands will be on the genitals due to some discomfort. And bacterial vaginosis it is a vaginosis and it is not a vaginitis. And the bacterial vaginosis it is a most common cause of vaginal discharge among reproductive age group women. Then bacterial vaginosis is a sexually associated disease and it is not a sexually transmitted disease. And the Center for Disease Control, they are not classifying it as a sexually transmitted infection, and there is no need to treat the partners. The prevalence are, it is a common cause in young reproductive women that we have already seen, and according to CDC, the 40 to 50% of vaginitis cases is due to bacterial vaginosis. And then the bacterial vaginosis, it is only the alteration in normal vaginal flora, the decrease in lactobacilli count, increase in other organisms like Haemophilus vaginalis, Gardnerella, Mobiluncus, and Mycoplasma hominis. Reduced glycogen content, it leads on to reduced acidity. Because of reduced acidity, everything happens. And then the risk factors are douching, that decrease in the lactobacilli count. The black rays, they are considered as an increase in alkaline pH. The smoking, the same reason. And then the sex during menses, because during menstruation, it is fluid is alkaline, and then the semen is also alkaline. So alkaline pH leads on to infection. Then IUCDs, early age of sexual intercourse, multiple sexual partners, and immunosuppression. These are all the risk factors for bacterial vaginosis. By definition, it is a polymicrobial alteration in the flora, increase in vaginal pH, homogeneous discharge, and absence of a demonstrable inflammatory response. This is called as BV. And then the gram-positive Dorderlin's bacillus. This Dorderlin's bacillus is very, very important for the vagina. And the three main actions of Dorderlin's bacillus are glycogen. The vaginal epithelium contains glycogen. They ferment, this Dorderlin's bacillus ferment glycogen from the vaginal walls into lactic acid, which prevents growth of infective organisms. The second one is hydrogen. The production of hydrogen peroxide by Dorderlin's bacillus, which is toxic to anaerobic microflora. And then the third one is micropylae. Then micropylae, they adhere to the receptors on the vaginal epithelial cells, thereby preventing the adherence of potential pathogens. So by three actions, these Dorderling bacillus are protective for the vagina. The organisms, the other organisms we are talking now. So what are the other organisms in bacterial vaginosis? They are Gardnerella vaginalis, Coccobacilli, and is the surface pathogen. Then anaerobic bacteria, these they are bacteroids, Mobiluncus and Prevotella, and then the Mycoplasma hominis. The symptoms, clinical features, they are usually non-irritable discharge with malodorous vaginal discharge. The discharge is malodorous, thin malodorous, non-viscous discharge. On speculum examination, there are no signs of inflammation and the discharge is thin and gray. What is your diagnosis? Definitely a bacterial vaginosis. And then the investigations, microscopic examination of the vaginal secretion, the wet preparation, it shows clue cells. That is 20% of epithelial cells on microscopic examination should be clue cells. When you see the clue cells, it is a 95% positive predictive value for bacterial vaginosis. And then the second one is vaginal pH should be alkaline. And then the whiff test. Whiff test, by addition of 10% potassium hydroxide, it causes fishy odor. This KOH releases the putrescine and cadaverine from the secretions. So this putrescine and cadaverine, they are volatile. And because this only, the smell is coming, the fishy odor is coming. Then the clue cells, this is the typical picture of clue cells, the epithelial cells in which bacteria adherent to the cytoplasmic membrane and obscuring the cell borders. The cell borders are obscured because of the adherence of bacteria. They are rod-shaped bacteria, BV rods. BV, the microorganisms are rod-shaped and they are adherent to the inner surface of the cell membrane. So this is the typical picture of clue cells. And clue cells should be 20% when you see in the microscope. When you count 100 cells, the 20 cells should be clue cells. Then only it is a diagnostic one. Then coming to the Amsel's criteria, in the Amsel's criteria, 3 should be fulfilled among the 4 criteria. Number 1 is homogeneous, thin, milky, grayish discharge. It is sticking to the vagina. Number 2, pH more than 4.5. And then the third one is presence of clue cells in wet prep. And then fourth one is positive amine test or whiff test. It is fishy odor on adding potassium hydroxide. This is called as positive amine test. So these 4, among these 4, only 3 is enough for the diagnosis. And then the diagnosis, the sure of diagnosis is mainly by the Gram stain, is the definitive test for the confirmation of the bacterial vaginosis, and a culture is not at all recommended. Then Nugent score in Gram stain, scoring for vaginal swabs to diagnose bacterial vaginosis. It is calculated by the presence of large gram-positive rods in the Gram stain. So when the score is 0 to 3, it is negative. And when it is 4 to 6, it is called as intermediate. And then when it is more than 7, it is called as positive for bacterial vaginosis. The complications due to bacterial vaginosis are psychological disturbance for the patient who is with the BV. And then pelvic inflammatory disease is very common. And that leads on to chronic pelvic pain, tubo-ovarian abscess, infertility, and etc. etc. Post-hysterectomy vaginal cuff infection in gynec patients, then urethral syndrome, susceptibility to HIV is more common with BV. Then BV in pregnancy, it has clear association with premature rupture of membrane, preterm premature rupture of membrane, preterm birth, and postpartum endometritis. Then antepartum treatment with bacterial vaginosis. Antepartum treatment of BV reduces the risk of preterm birth. And it is unusual for BV to develop in pregnant women after 16 weeks of gestation. So after up to 16 weeks, the possibilities are more. After 16 weeks, it is very unusual to develop newly in a pregnant woman. And all preterm PPROM, PROM, everything is with BV. So we should treat the BV during the antenatal period itself. Then obstetric complications are, they are listing out the complications like miscarriage, post-abortal sepsis, preterm labor, bacteremia, chorioamnionitis, cesarean section wound infection, postpartum endometritis. Then the treatments are, we should advise the patient about personal hygiene, because many patients, they don't know what is personal hygiene, how to change the underwears. Then use of cotton underwears is very important. Then metronidazole, the antibiotics is metronidazole is a drug of choice, 500 milligram 2 times daily per oral for 7 days. Or metronidazole, that is 0.75%, 5 grams intravaginal application once daily for 5 days. Or clindamycin cream, 2% cream can be used 5 grams intravaginal application at night for 7 days. Then the alternative regimens are metronidazole single dose, that is 2 grams single dose can be given, but it is only 40% effective. Then clindamycin 300 milligram BD for 7 days is very effective. Then clindamycin ovules, that is 100 milligram intravaginally at night for 3 days. Then capsule cephalosporin 500 milligram BD for 1 week. And then the capsule doxy can be given 100 milligram BD for 10 to 14 days for, that is 2 weeks. Then treatment in the pregnant women. Pregnant women, we can give the metronidazole 250 milligram 3 times daily per oral for 7 days or clindamycin 300 milligram BD for 7 days. And then recurrent bacterial vaginosis. The recurrence within 3 to 12 months is in a previously treated women. That is called as a recurrence. Within a 3 months or up to 1 year, they are giving the time period for recurrence. Then the suppressive regimens to be used. Metronidazole jelly intravaginally weekly. They can use the jelly every week for long term. Then lactates intravaginally for 6 months. And then acidifying lactate vaginal gel. That is 5 ml daily for 7 days. This acidifying gel which increases the pH of the vagina. Vaginal probiotics can be given. That is Ecoflora capsule, which contains the Lactobacillus rhamnosus and Lactobacillus reuteri. So this is women with discomfort. And thank you all for patient hearing. This is about my topic.
Thank you, Dr. Tamilkode.
Thank you, ma'am.
Thank you, madam, for that elaborate discussion on BV. As you said, many young women who are adolescents and teenage girls, they keep saying they are having white discharge and they think there's something wrong with them. And we have to be telling them about hygiene and it may be physiological. Yeah, we have covered exhaustive. Thank you, madam.
You're muted, ma. Not hearing. Dana, we are not able to hear you.
Yes, ma'am. Yes, ma'am.
I call upon Dr. Dhanlakshmi, our Honorary Secretary Oxy, and she's a professor from Sri Ramachandra Medical College, a special interest on medical education, endoscopy, vaginal surgery, and high-risk obstetrics. Over to Dr. Dana.
It gives me immense pleasure to give this vote of thanks for this excellent CME on this special day, International Women's Day. And I extend my warm greetings to everyone who are gathered here. And also my special thanks to the chairpersons, Dr. T.S. Meena ma'am and to Dr. G. Rohini ma'am, who have taken their time off from their busy schedule. And they have been with us for the last 2 hours. And thanks to the speakers, Dr. Bharat, Dr. Tamilkode, Dr. Kundavi, and Dr. Deepa Tangamani, who have rendered their lectures in a well-structured way. Even though the topics were diverse, they all were pointing towards one thing, that is wellness in women, how we can achieve it by different means when there are different problems. And I also thank Sri Events, who had given a flawless platform to host this event from Oxy's side. And I also thank Mr. Jauhar, a representative from Abbott, who had been kind enough to host this event from their side. And I also thank the Almighty for making this event on this special day, International Women's Day, a flawless program. And thanks to all the delegates who had logged in for this day. And we'll see you all again on Thursday on yet another special CME on account of Dr. Seshaya's birthday on 10th of March. So we are having more or less the same timing, 4:30 to 6:30. And please, I request all of you to log in again on Thursday, the 10th of March.
Thank you, Premalata ma'am and Dana ma'am for giving me the opportunity, and Dr. Meena madam for co-hosting and the chair.
Thank you, madam.
And thank you all the speakers and my chairpersons for this meeting.
Happy Women's Day to everybody, not only for today, for every day of the year, for every day of your life. Let us all be happy, being born as women.
Happy Women's Day to all of you.
Thank you, ma'am.
Thank you, ma'am. Thank you, Premalata ma'am. Sorry, ma'am, I couldn't pick up your phone because I was connected through phone. So if I pick up, I lose my connection. Thanks, ma'am.
Thank you. So let us now close. We'll meet on 10th. Thank you.
We'll meet on 10th, ma'am, again.
Premlata madam, thank you madam for
you.
giving me this opportunity.
I'm happy to see Dr. Tamil Kode. She did MD when I was an assistant professor in RSR. Nice to see you, Dr.
Tamil Kode, congratulations.
Thank you, ma'am.
Tamil Kode,
Yes,
thank you. Nice to see you. Nice to see our own children coming up nicely. Thank you. All the best.
Thank you, ma'am.
Good job. Okay.
Thank
Bye.
you.
Thank you, madam. Thank you.
Okay, bye.
Thank you, ma'am.
Thank you, Dana.
Thank you, Sita, for chipping in.
Yeah, thank you. Thank you.